extension of community healthcare outcome session. I want to especially welcome all the facilities that are joining us for the first time, in particular Ndola Teaching Hospital. Also a special welcome to our new mentors who are undergoing orientation, the MOH CDC orientation. We want to welcome all of our facilities. We see Nakambala, Kaoma, Senanga, Sichili, St. Francis, Chipata, Mongu, Choma, Chile, Bula, and those that are joining us as individuals. A humble request that every Okay, so I'll use that microphone.
As you connect it.
So we can go into the didactic, but before we do that, we'll allow Sister Mamba to give us a recap of last week's topic, which was care for the HIV-infected infants.
Good afternoon. A quick recap of our last week's session on the 30th of September 2019. HIV-infected infants. Presenter was Dr. Muya. The meeting started at 14:30 exactly. We discussed that in children, HIV infection is confirmed by age-appropriate test. In children less than 24 months of age, we use NAT. In children above 24 months, we use serology test. All HIV-infected children are eligible for ART. We use comprehensive package for care of HIV-infected children. No HIV-infected child should be on. No HIV-infected child should be on AZT, NVP beyond 14 days of age. We also discussed that we have to initiate Septrin at 6 weeks of age for infants. All under 5 vaccines should be given. We should also monitor all the children's growth and development. Thank you.
Thank you so much, Sister Wamba. So I've been thinking, because Dr. Muya actually sort of preempted our new guidelines, and I've been thinking 20, 25, and 30 kgs. At 20 kg, you can now introduce dolutegravir. At 25 kg, you can introduce TAF. And at 30 kg, you can introduce your tenofovir. I thought that was interesting. Thank you very much, Sister Mamba. We'll now just go into the didactic.
Okay. Good afternoon, everyone. It's good to be back on ECHO again. Today we'll look at retention in HIV care. So this is a very important topic, and I don't claim to be an expert in this topic by any means, but I'd like this session to be more of a discussion than a one-way traffic kind of a thing. Next slide. Yeah, so I know we did discuss retention in the past, but today I would like us to look at it from a the programmatic point of view. So we'll not be looking at retention as, from the angle of a client, but at a facility level. So we want to discuss just definitions of retention at the retention-related definitions. We want to look at the patient tracking systems at the facility and discuss some of the pitfalls in that process, at the facility level and some of the reporting requirements. So as usual, we'll start with a polling question. Dr. Foloshu will help me with that.
Okay. John's ART clinical appointment was due yesterday, but he sent his wife to pick his drugs without a clinical interaction. Which of the following is true concerning John's status? John is lost to follow-up because he missed his appointment. John is late because he didn't show up for his appointment. The counselors should immediately follow up John within 30 days before he is classified as lost to follow-up. None of the above. I cannot see the poll. Chatonda, do you mind polling? I can't see the poll here. They are not loaded. John's ART clinical appointment was due yesterday. That's the third one. But he sent his wife to pick up his medication without a clinical interaction. Which of the following is true concerning John?
So you are free to look at the options. Yeah, so the first option is John is lost to follow-up because he missed his appointment. John is late because he didn't show up for his appointment. The counselors should immediately follow up John within 30 days before he's classified as lost to follow-up, and none of the above.
You can now poll. Apologies, we had a glitch.
We can see some
polling.
Some responses.
Makando, I hope the mentors are polling. I know that Lee went to great lengths to explain loss to follow up and the changes. So I hope the new mentors are polling. And I hope it's correct because we learned about it this morning.
We're actually working on it, Sombo.
Working. This is straightforward. Okay.
We are curious to see what the mentors will say.
Okay, we're going to end the polling right now. Dr. Sivile, can you see the results from Chatonda's screen? Chatonda, may we see the results? You can end the polling.
Yeah, so I can't see from here, Dr. Falash, can help me.
Okay, so essentially we have a few people almost equal, but most people feel that it's actually none of the answers you gave them. How deceitful. We'll see. So polling question 2. In an E-First ART facility, which of the following is correct with regards to the organization of your patient tracking systems? A comprehensive list of missed visits should be compiled weekly. B, a daily appointments list must be generated by the data assistant and given to counselors to send reminders to clients. C, missed visits should be followed immediately, preferably beginning the day after the day of the missed appointment. D, pharmacy pickup records only can be reliably be used to track ART patients in care. You can launch it. I don't have them here.
So again, we can see people are answering.
in an E-First facility, which of the following is correct? So there's A, B, C, and D. One of them should be correct, I hope, this time around.
Hopefully.
A comprehensive list of missed appointments should be compiled weekly. B, a daily appointment list must be generated by the data assistant and given to counselors to send reminders to the clients. Missed appointments visits should be followed immediately, preferably beginning the day after the day of the missed appointment. D, only pharmacy pickup records are reliable for you to track ART patients in care. So you can see the voting from that screen. A daily appointment. So we have people voting across. You can share the results. Okay.
Okay, so most people feel it's D. It's B, sorry. We'll see after the discussion. I think we can proceed to the third polling question. Dr. Faloshi?
Yes. Lydia has been on ART for 3 years, and now she reports an 8-week pregnancy in the general ART clinic. Which of the following is correct? Is the correct next course of action in managing Lydia? Lydia is now 8 weeks pregnant. She's been on ART for 3 years. A, should we refer Lydia to MCH for further ART management for the next 24 months, that's 2 years, with a new MCH-specific ART number? B, we want to refer Lydia to MCH for further ART management for the next 24 months while using the same ART number. C, MCH should have a separate set of tracking and tracing system. We can watch that, please. Okay, wow, it's overwhelming. Can you see the voting? Okay, so people feel that you should refer Lydia for further ART management for the next 24 months using the same number. A lot of people feel that. A few people feel that MCH should have a separate tracking system, while some people feel that you should refer her to MCH and she needs a new ART number. Interesting. We can share the results that's on the screen.
Okay, so a lot of people feel the answer is B, that Lydia should use the same ART number when she's referred to the MCH for ART, and she should be there for 24 months. All right, we can close. So we'll start with the definitions, and I think retention in care, I think in simple terms, just to keep ART patients in care. Yeah, I think we know the definitions of late. All these are from the soon to be launched, to be launched guidelines. So we changed the loss to follow-up to 30 days there. That's after the last scheduled clinical contact. And the definitions for a defaulter hasn't changed. And again, as it is in our current guidelines, the 2018, the definition for unknown status has not changed. Now we are using the term clinical contact, and this is defined as just can be anything, pickup, clinical assessment, or documented clinical community visits with a community health worker. So it's not necessarily something that should happen in pharmacy. So I think that speaks to the first question, that even if someone does not really have a clinical interactions, they can still be classified as loss to follow up. Next slide. All right, I think this is just to emphasize about the durations. You have a day of appointment. Just the next day after that, you've missed the dates, and up to the 30th day, after the 30th day going forward, lost to follow-up, and this will be in our new guidelines. Yeah, I think we have also stated there that follow-up and tracing measures should be started as soon as possible. Yeah, so visiting facilities, you'll find that the practices are so different. Others, they'll have to compile patients maybe for a week, others for a month. After that, then they start to follow up. But the recommendations we are giving is that just the next day after you finish your, the next following day after someone misses the appointment, the follow-up processes should actually commence. Yeah. So why talk about retention? Obviously, the retention speaks to the second 90 in the cascade. It's also, I mean, it's a predictor of the third 90. If patients are not in care, they're not taking their ARVs, they won't be suppressed. Yeah, and really it's a measure of how a facility is doing in terms of the quality of services. You know that we are putting a lot of people in care right now, but the emphasis should probably shift to talk about quality. What kind of services are we giving to these patients? And it has emerged as a prime challenge in terms of our HIV care services. Patients are being put on treatment, but we are failing in most cases to retain them. That's what the data is actually showing. So poor retention really speaks to attrition, that patients are coming out of care. In other words, our bucket is leaking, and that schema can show you that. Yeah. Point from experience again, the bucket might not be leaking as such, but you may just speak to our measuring capacities of what is in that bucket as well. How are we measuring the content of the bucket, and if at all, to see if it is leaking? As you can see, the numbers on the other side, we are looking looking at the so-called net change. You find that patients, the treatment curve is not increasing in accordance with how many patients we are putting in care. That's just in short, meaning that a lot of patients are being lost. Our bucket is not growing as much as depending on what we are putting in the bucket. Yeah. So the problem that we have a leaking bucket. Now, I wanted to look at these terms, tracking and tracing, just to pick it up from what I said, to say that sometimes the bucket might not really be leaking, it's how you measure it. So I know we use these terms interchangeably, but really the meaning should be different. Tracking is really the process of following up something, following the patients who are actually in care. And really the question is, how is our data management systems and their use, in our facilities? You visit facilities and see that we cannot account for patients who are active. We are not, updating the records and so on. So that tracking process, in most cases, you find that the ball is dropped. Then tracing really is, as we use it in the medical field in terms of contact tracing, where if someone is out of care, you go in the community to find these patients through investigative means. Typically, we use a call or a visit and things like that. But really, let's think about tracking as how do we follow up the patients who are in care in the first place before we look at those who've fallen out of care, because you find these fluctuations in treatment curves are really a worrying phenomenon, and we need to do a little bit better in that regard. Yeah, so how do we report this? Typically, as was presented some time back here, we use the TXML, and this is done typically every quarterly indication, and it's something that we've discussed. It's really a new indicator, but I think we've discussed in full here. Unless we want to add some new things to this, we'll give maybe some time to just probably if he has something to to emphasize. Yeah. Yeah. So why have we changed the period from 6 months? Is it 60 days to 30 days? And really, this is just to follow up these patients a little bit closer, so that we can have everyone in care achieve our U equals to U. That's the basic, reason. And I think evidence is there to show that if someone is out of care for a longer period, you'll find that it becomes difficult to find them. And indeed, if you go in most of these registers where they're tracking patients, you find that actually, if they institute measures, a lot of patients are found to be active. In most cases, you find someone missed treatment because they had the funeral or they went to visit and things like that. But as we leave patients longer off treatment, out of care, it becomes harder to bring them back into care. Yeah. Now, at a facility, the tracking of patients must be a daily activity. I've visited facilities where, like I've said, they compile and they have to do it maybe monthly and things like that. Probably that's not the correct way of doing it. Well, the advice is let it be done every day. At the end of the day, you should have a list of how many patients didn't come to care. Yeah, and we'll show some of the practices, as we move on with some slides, and this tends to work better. Then you can account and for why the number is fluctuating. Yeah, so we also encourage that there are personnel who should be responsible. And I know as we organize these RT clinics, we have a lot of blind spots where there's nobody really responsible for something. But here we are encouraging that let's put someone responsible. Typically, it's encouraged that the data clerk or someone of that similar standing, but that should not be the only person involved in tracking these patients. And there are various tools that you can use: registers, the EHR, pharmacy systems, pickup, the LIMS, and so on. And now we've introduced the case-based surveillance, which will track patients as they go in care. Yeah, but I think the biggest emphasis I have here is these registers and EHR systems are there, but they will not work until people use them, until people use them. You need to be committed to using these systems if they'll have to work. As the adage goes, garbage in, garbage out, Yeah, so really, tracking of patients in a facility really starts with your appointment system, because that's the first time that you notice that someone is out of care, if at all, if they don't come for the appointment. And there are attempts which we will communicate as time progresses. We are trying to recommend new forms of appointment systems. But in the meantime, there are some things that people are using. People have got this, those who have paper-based, they're improvising with books, and so on. But we'll put, recommended registers to follow up these patients. Yeah. But the main point is we need to manage these appointment systems well. And in practice, we found that in facilities where a week before they prepare a list of who should come, not every day, but a week before they prepare who should come to the facility, and they make prior calls, you remind SMSs or whatever means. We have all these community services to remind these people to come for care. That tends to work well. And again, the way you place the appointments, you should have a fixed number, of how many you can have, space them well, in sometimes it's encouraged that you give them, specific time allocations just to improve that quality system. And I don't know, Dr. Folosh, if you've already had a session on appointment system specifically. I think we've had, right? Yeah, or who have in future. All right. Yeah, so in those patients that have been lost to care, this is a sample of, those patients that have missed appointments. This is just what we are trying to recommend, a tool for following up the patients. This has been used by one of the IPs, but we are trying to adopt it as a national document. Yeah, so really major changes here. We are emphasizing that maybe we should be having 3 to 6 attempts when following up a patient. Obviously, at the end of each clinical ART clinic day, you need to generate a list of the patients who've missed appointments, and this can come from the appointment registers, like I've mentioned, or from the smart care, or is in a community model. Yeah. Then immediately, preferably the following working day, if it was on a Friday, you start the follow-up processes, and if the patient is found, as you can see, you are able to locate the patient, to return them to care, but if the process itself should involve going back into the locator, you call the patients, you can send SMSs, you can have home visits. Yeah, but if you really look at this is so comprehensive and helpful, and we hope this is the SOP that most of us would probably follow or do a similar thing as we follow up these patients. This tends to work well. But at the end of the day, you need to document what has happened to this patient. As you can see at the bottom, whether it's a loss to follow-up, the patient is dead, or indeed, if you found them, you bring them back to care. Yeah. So this is what we expect to happen in a facility. These are the processes that we'd like to see. Yeah, so we have community ART registered. It's just an example. I know this is on this side. Other facilities I've visited, they use different registers. Yeah, but this work well. One of the, the drawbacks of this, it doesn't give you the chance to watch the outcome. I know others are using tools that give the outcome. Yeah. You use something at the moment before we recommend a full thing. This is just an example, and these are the changes that probably needs to be done to this. Yeah, mainly it's just to include the outcome component to the register. Yeah, there are special populations, I guess, where the boy is being dropped, mainly in tracking and tracing pregnant and breastfeeding women. Here, there's a bit of confusion. I'm very impressed that in the question, almost everyone got it right. But really, the emphasis is there should be the same ART number, even when a patient is moved from the general ART to the MCH or PMTCT ART program. And you find patients are deemed as lost to follow-up when they've just become pregnant and have moved to the ART, to the PMTCT ART area. Again, the follow-up of pregnant and breastfeeding women, especially in the breastfeeding period, you find that the tracing mechanisms or systems in facilities work well for the other population. But we know the data is showing that there's a lot of dropouts, as in patients, in mothers after they deliver, they don't continue to come to care, and that has resulted into this mother-to-child transmission of HIV. And so the emphasis is whatever system you are using to follow up this group and also the general ART group. If anything, there should be a lot of emphasis to say that if a mother, has delivered, they should be followed up, and in the new guidelines, hopefully we might, even, make the visits even more strict, the follow-up and the monitoring more strict in that specific population. There's an issue of tracking patients and the DSDs. We know this has been a challenge. Yeah. there's this thing where, you know, when people are making these appointment records, they are putting even patients who are on DSDs there, and then you have an exaggerated number of patients who are lost to follow, when those patients are actually maybe in a DSD picking drugs from a health post and things like that. So we are encouraging that these processes should be streamlined, you know, where the patients who are on DSDs, they should be followed up in a streamlined manner, and you merge the data together so that patients are accounted for properly. But by and large, there's just need for enhanced data management and accountability in that population. Yeah, there's a lot of confusion as well when you look at DSDs and tracking patients. Yeah, I'd pick some common pitfalls that we see when we visit the facilities in retention. Mostly complaints of missing and incorrect client location for information, you know, phone numbers are not going through. You visit these patients, they're not being found. We feel these challenges, you can go around them. One of the ways is to have multiple numbers. I think if you see the new ART forms that will come, those provisions are there where you put numbers for other people, or if a person has got several numbers, you can put the other phone numbers there. You know, people change numbers all the time. We can't force them to stick to one number. In the ART form, we've emphasized on periodic updating of locator information, which is never done, because as patients are coming for reviews, and a deliberate attempt should be made to look at the locator forms. Is the information still accurate? If at all it's not accurate, let's change it. If you go back, what you find the details which were put in 2006 are the ones still there. A patient has moved on. The other pitfall is high rates of unknowns, and this is what you find from the data. And this just looks at our practices in the facilities. Let's adopt the algorithms that I've shared so that patients are followed up quickly. The complaints of resources, obvious for tracing processes. We don't have talk time, fuels, and the other. And again, just the data management processes, you know, just the fidelity of handling this process. I think this is a big pitfall that we see, you know, before we blame the systems that we have. Yeah, so this is just an example of what we see, say, in Lusaka here. Sorry to put Lusaka on the spot, but as you can see, you know, recently you have as high as 45% of patients missing their visits. And it shows that, you know, the appointment system is not being done properly. You know, it just starts at that point. If someone can't manage to come for these visits, we need to ask ourselves questions. Is it maybe, do we need DSDs? Do we need, proper, ways of asking these people to come back for appointments. Yeah, and we pick this data from here, so what it gives you will be probably misleading at the end of the day. Yeah, so this is just an example. This is also just to show some of the data we have, that actually there's a huge, you know, percentage of patients who you find where there's no attempt to locate the patient, you know, and unable to locate the patient. You find that this about 80% of these patients who don't come, none of us can explain why they didn't come, you know, because we didn't put in those measures in the facilities, you know, to follow this, to do this work. Yeah, so in summary, the main point I want to deliver is that we need dedicated persons for this tracking and tracing activities. It should not be left to data clerks only, but clinicians come on board. You know, I visited a facility where, you know, a list is made from the data people and it's taken to the pharmacy, you know, where they see who's come, and no one knows what happens to that list after that, you know, because it's not taken as a priority. I think we can do better with the tools that we have if we just work a little bit more, we show a little bit more commitment to this problem of retention that we have. Yeah, obvious data management issues is a problem. I know some issues are genuine concerning smart care and the like. Yeah, we need better tools like the one that I've shown for follow-up, you know, and I guess this is an area where we need people to come in with continuous quality improvement innovations, as it were. So thank you very much for your time, Dr. Folosha.
Thank you so much, Dr. Sivile. We will now allow for comments and contributions from our network as we prepare to share our case. Are there any questions or contributions from the network? If there's a chat. Do we have any questions from the network, any comments? Or was that so clear before we turn to the hub? We're going to put the mentors on the spot because I know that's a lot of brains in one room. I'm sure someone can come up with a question.
One answer.
We are unmuting you now. Makando, please unmute the mentors so that we get contributions and questions for Dr. Sivile, and there's also Maid in here. I believe even Professor Lloyd was here, and he'll be back. Okay. So we'll allow the mentors to go with a question. I see Mary is trying to take the microphone. Do we have any comments on this issue? I know we are, oh, I see AIDC people have joined in from AIDC, where my office is, which is good. My threat worked. So are we getting a question from the mentors, Mary, or should we move to the hub? Do we have anything in the chat on that? Where is that? Can we get that from there? Chainama, please go ahead. Chawama, please go ahead. Can you unmute them, please?
Okay, can I ask? Yeah, right. We have a question.
Yes.
Yes. We just wanted to find out how would you how can we manage a client who was lost to follow, let's say after 30 days, and then they return to care? Like, where do we start them from? And then you find that this client is also eligible for viral load. Like, we're supposed to collect viral load for that client. Are we supposed to collect it immediately we meet that client, or is there a procedure we need to follow?
Sorry, who's asking the question from Chawama?
Yes.
Who's asking the question? Okay, we have just one question. When you lost this patient to follow-up, you need to be very clear. Did they also stop taking their ART?
Yes.
So they stopped their ART and now they have returned to care. They are due for a viral load. Dr. Sivile.
I think that the question is in two parts. The first one I would ask maybe to help, maybe in how do you handle a patient who's in terms of the data? Do you just throw them back or in the system, or there's another place where you record them?
Process. Okay. Okay. Thank you, Dr. Sivile. Yeah. So how would you handle a patient who returns back to care? I think first of all, we'll be excited that this person is back to care, so that they can continue receiving treatment. So immediately they are back to care. That means they will get their treatment. They'll get all their clinical assessment. That means they will immediately be added to the count of number of people on treatment. And that means the status has to be changed. If the status was indicated lost to follow up in smart care, you have to make sure that that's another additional step to go and change the status to indicate that the person is active. But what is also good is that PEPFAR has added another indicator, which is called RTT, return to treatment. So this is so that such a person, actually you're going to count them under the RTT, the returned to treatment indicator, so that we know how many are returning back. after we declare them lost to follow-up, and they return back. So that will be captured and counted under that new indicator. And that new indicator is going to be collected every quarter moving forward. And also just to add that as well as TXML, now it will be quarterly, beginning this quarter. So instead of doing 6 months, they've changed that to So that's why you would report such a patient. And what they've done now is that even with the TXML, the mortality and lost follow-up indicator, they would want to also track those that were lost follow-up after starting treatment within 3 months, and those that were lost to follow-up after starting treatment, like their long-term patients after, who are more than 3 months on treatment, so that we can just track the early retention. Because I think what data is showing us that I think we are losing, most of the patients we are losing are those that just started treatment. So it's very important that we categorize our records and our reporting, so that we are able to tell how many were lost to follow-up, how many fall under TXML, who are new patients and old patients. Yeah. So, and maybe also just to add in terms of retention, that we also have a bigger gap amongst the children. So I think if we could focus more, I like the flowchart that Dr. Sivile shared. If we could also focus our energies in retaining the children. I think the data is showing that about 70% of children who are started on treatment are likely to return back for treatment, which is, we are losing about 30%. So it's very low among children, and you can relate this to even the suppression, because the suppression rate for children is just about 77%. So like Dr. Sivile mentioned that the loss to follow up, the retention informs the third 90. So if they're lost to follow up, then they're likely to have that addition as well. Thanks.
Thanks, Bevin. Concerning the viral loads, so typically what we ask is you put the patient back into care, they start taking the ARVs. There's no need, if they are not taking the ARVs, there's no need of doing a viral load because it will still be high anyway. So you put them on ART and obviously enhanced counseling. You make sure that they're taking their drugs, and you repeat the viral load probably in an earlier time than usual. So at this point, we'd recommend a repeat viral load at 6 months. Yeah, that's how you'd handle them in our system.
Okay, so the RTT, you put it back on treatment. Mary Beg has sort of a different thought to you. Do you want to comment? They are saying in an instant where such a client goes on TLE, we will need to do a viral load to rule out possible treatment failure. We will also have to do all baseline tests before we started on the same TLE, and only to switch them to TLD after the viral load result. Do you want to comment on this? They're suggesting you do a viral load now.
Yeah, so probably if I think the situations will differ. If someone tells you, I wasn't taking medicines, and they didn't come for the last 2 years, they were not in care, not taking drugs from anywhere, there's no need in our guidelines to do a viral load at that point. So you start them on treatment, and at that point, you not know whether the TLE is working, that is if they are on TLE, or if it's not working at all. You will not know if there's resistance or there isn't. So you put them back on treatment, give them some time. 6 months will be a good time to repeat the viral load according to what we recommend. Other places, they'll do it quicker, that is maybe at 3 months, but here at 6 months. If the viral load is too high, then you consider after you ensure that you are confident that the patient is actually taking the drugs. Yeah.
So Mr. Andrew Manga, do you mind unmuting yourself and making that comment you've typed in? I think it's very useful and very important, aside putting the patient back on treatment. Mr. Andrew, please go ahead. Andrew?
Yes, I can hear you.
Please go ahead and make your contribution.
I think even as we are trying to restart this patient on treatment, we have to make sure that we do enhanced adherence counseling sessions to make sure that adherence is taken care of. Thank
Spot on, Andrew.
Yes, correct, Andrew. Yeah, so you counsel these patients, and I think that's the most important thing actually than even rushing to give the drugs or changing the treatment. You know, let's ensure that this patient is counseled properly. You know why they fell out of treatment. You know, if it was toxicity or whatever, all those things are corrected as we usually teach here.
Okay. So we welcome Kafue General Hospital. We also welcome Nangongwe, Phyton, Veronica, Dr. Annie, Maryberg, Linda, and Chifundo Clinic. Kanyama, please go ahead with your contribution.
Okay, good afternoon.
Good afternoon.
Good afternoon.
It's a comment and a question on the retention system. There's a system that was which is actually training facilities where the situation of where with a good number of clients that come routinely to our facilities to come and maybe request for some medication for one or two reasons. As a result, we try to help, but you find that these people have these standards. Maybe today they'll be at this facility. The next time they run out of drugs, they'll be to the next facility. The other time, next facility. And we feel that also can contribute to the publication that we will be facing. So I don't know if there's any measures which can be put in order for that to be controlled, but we strongly feel that contributes to the problem as well.
Okay. Yeah, thanks Kanyama for that question and comment. Yeah, so that's a common scenario. The first issue is, I'll start by saying, sorry to say this again, it's our attitude as workers, health workers. You know, typically from the past, if someone comes to get ARVs or, you know, when they've moved from somewhere else, the processes were a bit stringent, you shout at them and so on. So from that angle, I think our recommendation right now is if someone comes from somewhere else to come to get ARVs from your facilities, first, don't make their lives difficult, welcome them. And in that place, you need to counsel them. Why are they here? One of the things that I didn't want to talk about is silent transfers. So there are a lot of patients who are moving from place to place. So how do you best deal with these patients? One is, they are moving from one place to another place, so the responsibility is where they are coming from. They are coming to. If I'm receiving these patients at Kanyama, last week was at George, they are coming to get ARVs from here. Why can't I counsel these patients, talk to them, the importance of being in care? And in one instance where we had to find a patient like that, we had to even communicate with the facility where they were coming from, so that you formalize these transfer processes. I think that should be the approach, as opposed to the approach we used to have in the past, where we make the life so hard for these patients. So I think the answer to that question is counseling and counseling, because really patients are going to move from one place to another, because this is a lifelong condition and life circumstances do change. But if it's hard for a patient to come and get a transfer, you make it so difficult, and if it's hard for a patient to re-engage into care where they are going to, because like one patient that I met, they'll come to this facility, they will not stay in that facility not because they don't want to stay, because you have that limitation where, no, you don't belong here, I can only give you ART for, is it 2 weeks? I don't know 2 weeks. Then the patient will get the 2 weeks and they'll be innovative to move to somewhere else, and they keep on jumping, from place to place. Why not sit them down, talk to them, what's your difficulty? They'll tell you, I've moved, but I didn't formalize, and formalize the process. And in that place, it works better. Because if a patient comes to your facility to ask for drugs, then that's a good patient. That's not a depot. You know, it's a plus. The patient still wants to be in treatment. Why not help that particular patient?
Thank you so much. We always have to think about differentiated service delivery.
Exactly.
And tell them what options are available for them. Going back to that, I think they are worried that deaths are really reported, so that affects the retention. Then, Bill, you can ask your question. They are saying deaths are rarely reported, so it affects retention. So the patients are dying at home, and then they don't get that data back, and then they're so not lost.
Yeah, that's true. And I think there are, not to preempt, several, I think, interventions which you hear about to see how best we can monitor these HIV-related mortalities. I think there are some projects that will be starting very soon. Yeah, that's correct.
Dr. Bill, please go ahead with your question. Dr. Bill Kabala.
Yes. Yeah. Good afternoon.
Yes.
Yes, I would like to understand what makes the retention difficult for patients on treatment on ARVs compared to other chronic diseases like diabetes. Those guys, they come from far, they will stick to their appointment. Why this on the ARVs, they don't stick to their appointment? What makes it difficult?
Wow. Amazing. That conclusion, Dr. Bill. Do you have data to support your conclusion that other people with chronic illnesses are more adherent?
Yeah, I've seen like people who are taking like they are taking insulin. They are more adherent compared to people that we are really struggling to make adherent to become adherent to treatment.
Are you at Petauke?
Yes, I'm at Petauke. Yeah.
District Hospital. Okay.
Yes.
I used to be there. I'm sure you know, and we had a very good diabetic clinic that you are referring to. So that's an example of a DSD. You know, the one that happens on Friday, you know?
Yes,
yeah?
yes.
Nicely the way you do them for that clinic. People come, even if it's very far. So there are several reasons why people fall off out of care, but you find that when you do the analysis, there are personal issues like, you know, patient factors, but most of them are actually systems factors, meaning that we can do something about it, like, you know, attitude, congestion, and so on. Even there at Petauke, you can tell me that the attitude that people have, you know, towards the ART clinic and the diabetic clinic, that's the healthcare worker, is different, you know. So they'll, you know, diabetic looks like any other disease, HIV, the stigma associated to it. So those are challenges that as healthcare workers, we can actually overcome. So what you've said is actually a very good example. If we can cross certain barriers ourselves, you know, offer good DSDs, get rid of stigma, these patients will be coming. I know there are some people who come from Musandwe, you know, very far to come to get the insulin there. So if you can have a similar kind of service, they will come, you know.
Thank you so much, Dr. Sivile. Because I want to hear the mentors speak, there's so much silence. I'm worried. I hope Makando and team, you can hear us. But I know last week, Lusaka was talking about having a retention champion. I think it was Dr. Fiona or Dr. Monica. Are they able to just briefly, maybe in a minute, tell us what the retention champion does at that facility? Makando, can you hear us?
Dr. Sombo, we will have a comment coming in.
I think Monica standing up, and I'm very happy because she talked about retention champions. I think it was Chawama or something like that. We want to hear more about this because it looks like retention is one of our areas in the program where we are struggling and we need to do something urgently.
That's one. Okay. Good afternoon. Can you hear me?
Yes, Monica.
Okay. So this is a chipata. We identified a retention champion. So his sole responsibility for the day is to come in and print out the appointment list for that day and for the next day. And he'll start calling clients prior to their appointments, start calling them in that they'll have the appointment the next day. And then he'll start calling the patients that missed the appointment the previous day.
Thank you so much, Monica. Yeah. So that's the experience from Chipata Clinic.
Yeah, so that is really encouraged. Let's have dedicated personnel to this tracking and tracing activities, including things like deduplicating, processes, because some patients move from, a facility 5 kilometers from there, and there's no one to see if there is a new patient or old patients, as we've discussed when we were talking about silent transfers. We feel just human activity, human work, someone being dedicated can really make a difference, before we look at technology.
So we are relaunching the poll. Please feel free to vote and tell us the answers, Dr. Sivile.
Yeah, sure.
John's ART clinical appointment was due yesterday. He sent his wife, so he didn't have a clinical interaction. What is he? Is A, John, a loss to follow up because he missed his appointment. John is late because he didn't show up for his appointment. The counselors should immediately follow up John within 30 days before he's classified as lost to follow up. None of the above.
So the answer is none of the above.
End the poll, please.
Thank you.
Yes, go ahead. No, that's okay.
All right, yeah, so the answer is none of the above, because really, the other three are not really correct. Let's go.
Okay, yeah. So the next one, launch it, Chatonda, from your screen. In an e-first ART facility, which of the following is correct with regards to the organization of the patient tracking system? A comprehensive list of missed visits should be compiled every week. A daily appointments list must be generated by the data assistant and given to counselors to send reminders to clients. Missed visits should be followed immediately, preferably at the beginning of the day after the day of the missed appointment. The pharmacy pickup records are the only reliable way for us to track ART patients in care. So, you can go to end the poll.
End the poll. Yeah, so I think C is correct, as a lot of people have picked. Yeah, so the first one, a comprehensive list should be made every day of those who've missed the visit, and appointment lists should be made a few days before so that you can remind people and so on, not the same day of who should come, like Monica had said. So that tends to work well. So that, like she says, should be maybe a day before so that people are called, or 2 days before, as it's done in other places. So C is correct. Immediately someone doesn't come, almost the following day you start calling them, because the earlier you remind them, the better, And D, probably here it's just to emphasize that while pharmacy pickup records are probably reliable to tell us who's coming on, they might not be the only records. Let's have the habit of triangulating record systems so that we come up with one good data, of who's coming, who's not coming. You cannot just use one place. Obviously, the pharmacy system is reliable. Yeah.
Number 3, let's launch it. Lydia has been on ART for 3 years. Then she turns out pregnant at 8 weeks. What should we do for Lydia? A is to refer Lydia to MCH for further ART management for the next 24 months with a new MCH specific ART number. B is to refer Lydia to MCH for further ART management for the next 24 months while using the same ART number. C, MCH should have a separate set of tracking and tracing systems. Oh, wow. There you go.
There you go.
How many people have voted? a lot of people haven't voted. The few that have voted have gotten 100%. So
there's a small percent.
There's a small percent. Okay, maybe we should end it.
Dr. Sombo, you haven't launched.
No, I haven't relaunched. Some people have voted. Do you want to relaunch it, Chatonda? We are launching from Chatonda's because they were not uploaded on my computer, unfortunately. Okay. If we launched it, can we vote? What should happen to Lydia? Should we give her a new number? The same number? Should the MCH have separate tracking and tracing system? So we are seeing people voting here.
All right, I'd like maybe to comment on that one. Maybe, the question. Yeah, the tracking systems for MCH versus general ART, then how the numbers get mixed up and so on. It sounds so straightforward, but I'm sure you've found these challenges as you go in the field.
Yeah. Thank you very much. Yeah, so I think we seem to have a lot of systemic issues regarding the triangulation of information between the general ART and the MCH. So if someone doesn't maybe inform the facility that they are now accessing drugs through the MCH, they may be categorized as lost follow-up. And yet they're actually not lost follow-up. So I think systems should be in place that information is triangulated between the two. That is, if she returns to ART, again, it should be immediately updated from the MCH department that this client has returned to the general ART. So it's the issue of the referrals being very strong there from the general ART and to the MCH department. Where you have electronic system, it actually works well because the two data sets would be merged. That is where you have smart care. So you would immediately have information merged within the system without manually actually transferring those patients, unless where they start from another facility. So I think what is important, I think like Dr. Sivile mentioned earlier, is also to establish that this patient is a lost follow-up, after you have made all the efforts to follow them up, or if they tell you that they're actually at in MCH, you make follow-up with that facility to get the information and confirm that this person started receiving treatment through the ART in MCH program.
Okay. Thank you, Mavi.
So she should be transferred to MCH for the next 24 months, but she uses the same number.
Yes.
So guys are using big words. What's triangulate? Just under the case. What is to triangulate?
Maybe.
I'm hearing triangles.
Yeah.
What does triangulate mean?
Question.
Everyone is using the word triangulate.
What is to triangulate? So to triangulate basically is just to cross-check various sources, various places before you can close out. So before you can say,
don't conclude on a patient.
Yes. So you
triangulate.
Exactly. So you cross-check various sources. So someone talked about someone dying. Say deaths also contribute. I think that indicates that CXML as a category. So we are again accounting for everyone. So if they've died, we need to account for them as well as what we know, and also get the causes of the death so that we know what actually caused the death for that patient.
That makes a lot of sense, especially with DSD. We need to be very careful with our records. We shouldn't cause someone lost to follow up or missed appointment, but they're in a DSD. Dr. Lucia, pick up the case, please.
Good afternoon, everyone. We are making a follow-up on a case which was presented in June, and the case was a loss to follow-up client. Today, we are trying to find out what happened from the time we presented to date, what happened to the client. Here is the case. Just a recap for those who didn't follow the case in June. This is an elderly client, 79 years old. He is in his second marriage. He has tested positive a few months after the death of the first wife. Is on treatment and declared lost to follow up for a year. The second wife is positive. The client opted to go for herbal medication because he was told the herbal medication is able to heal HIV. Besides that, the client is hypertensive and is on treatment. At the time of presentation of the case in June, these were the lab. In June, it was, the viral load was done in 2015, and it was 17,834. At that time, the client was lost. The time he was brought back into care, and because the client had opted to go on herbal medications, because he believed in the herbal medication to cure HIV, as to have evidence, a viral load was done at the time of return, just to have confirmation that he was still infected, and the reading was that the chemistries, the client has the creatinine of 129 in 2015, 120 in 2017, and the HB was between 14 and 14.3. We can move. At the time of presentation of the case, we had two questions. What could have contributed in this client to default treatment? And what else can be done to enhance retention in such a case? On the recommendations, we had 5. We had to address issues to do with adherence, which would have been the side effects, the long waiting time, the social environment, and the comorbidity with the client. The number 2, it was to address the cultural and religious aspect of belief. Number 3 was to switch the client to FED, considering the creatinine clearance, which was less than 50. Number 4, that was number 4. Number 3, it was about screening or having an ultrasound done to screen the prostate. Number 4, it was to switch the client on TAF-ED. And number 5, to change the treatment was the client was taking because the BP at that time was too high. Let's look at the follow-up of the labs. From the time of presentation of the case, that was June to date, we've seen that the client who had a viral load in March of less than 20 still have a suppressed viral load, which was done in October 3rd, which is still less than 20 copies. The CD4 is not repeated due to lack of reagents. On the chemistries, we've seen an increase in the clearance. The client at the time of presentation had a clearance of 40 to 45 mils per clearance. By this time, the clearance has increased to 56. And The HB is at 15. His VO is undetectable. His BP is at 168/92. His pulse at 67. An ultrasound done revealed that the prostate was normal. However, he is still struggling with the self-stigma and is still blaming the wife. From the time of presentation of the case in June, we had to carry out the recommendations, and 3 out of the 5 recommendations were done, except of the 2, which is switching the client on TAF-ED, which is not available, and handling of the client with a local physician who is not available also. Another thing we managed was to retain the client despite the self-stigma into care and have him still suppressed despite the pill burden. Today's question, looking at the pill burden and unavailability of TAF-ED, what can we switch the patient to TLD which is available? The other question, what additional psychosocial support can we offer to the patient to deal with self-stigma and stop the blame of his late wife?
Thank you so much, Dr. Lusa. I will briefly summarize that this case was presented in June, and this is ironically just 3 weeks before we launched TAF-ED. That's why we were confident that you'd be able to give this guy TAF-ED. So we'll let Davis answer that question. Essentially, he's a 79-year-old man that was started on ART after he lost his wife. Unfortunately, he was lost to follow-up for a year, on which he stopped taking ART. He preferred to take EBO medication, as evidenced by a very high viral load when he returned to care. Fortunately, by March 2019, they had managed to suppress him using the same regimen, which is interesting, isn't it? Because this was discussed. They used a backup at 3 TCA-efavirenz. They did not change it. They managed to get to less than 20. At baseline, he had a bit of a deranged creatinine. I think the creatinine was around, the clearance was around 48. That's why they used the backup, because anyone with a creatinine clearance less than 50, you need to use an alternative to TDF. Fortunately, the team has managed to maintain the client in care. He's suppressed. Their concern is the patient is really still struggling with psychosocial issues despite being suppressed. Their questions are, should we switch him to, what do? We don't have TAF-ED. Right now, the pill burden is 5 pills, I believe. So that's the question, Dr. Sivile. And the other one is, how can they help him with his psychosocial issues? So we'll allow the network to ask Dr. Lusa for any clarifications or questions. People in the hub are allowed to ask questions. It's very silent in here, I even forgot. Thought I was alone. We're allowed to ask questions for Dr. Lusa to clarify on this case before we return to the people that are here. Please go ahead. Suilanji.
Go ahead.
Dr. Chimonya, go ahead. You can unmute her. I've lost host power.
She's trying to mimic us.
Suilanji. Yes, we can hear you, Chimonya.
Okay, Dr. Lusa, I have a question. You said when the client returns to care, you did a viral load just to confirm his HIV status. Why did you do an HIV test?
Why did they do a viral load, you mean?
Yes, she said they did a viral load to confirm the HIV status. Why did they use a determined test?
Interesting. You heard the question, Dr. Lusa. Why did you people opt to go for a viral load and not just retest with your usual point of care test like determine? Thanks, Chimonya.
Thank you for that question. The question, actually, the client did not come in for himself back into care. We had to call him, and he was insisting that he was cured, or what he was taking was going to cure him. So we needed really to have evidence. And this is a knowledgeable client who used to be an accountant who has retired, who had issues to know that no, at some point, those who are taking, at time it comes out negative, even if you do it, it might not be so conclusive. So we opted to go for what would give really evidence, and that was the viral load. And when we came out with the result, he was able to accept that, for sure, I need to go back. And the suppression is an evidence that he really accepted.
Yeah, are you happy?
I'm okay, doctor.
Okay, it's difficult to make Chimunya happy. Do we have any other questions? She's just okay. But anyway, it was essentially because they felt that the viral load would be more informative.
Hi, Sambo, can we comment from the mentor retreat?
Yes.
Okay, so my question was around this individual's blood pressure. So I remember he had a wildly elevated blood pressure at that when that case was presented, and it looks like the repeat is also quite high. And I think I can't remember his pulse pressure, and I saw that they're still trying to contact someone to manage his hypertension. I mean, I'm just putting the whole thing together. This is an individual who has been, not easy. Or we, figure out the system to get him in care for his other chronic disease. And I know there was this question from Dr. Bill, how come we can get people to manage to take their diabetes medicine, but we can't get them to take their ART? But I actually argue that it's equally hard to manage high blood pressure and diabetes as it is for ART. But I see that we've kind of made it a secondary issue, and I'm wondering if he's one of those people who is really at high risk of stroking out on us and dying from cardiovascular issues if we don't handle it. So I'm just wondering how, I think we need to make a more accelerated plan to help.
Is as per recommendation after the presentation is taking fedpine, enalapril, and hydrochlorothiazide. But nevertheless, with the coming of the physician, the client will be linked to the clinician, to the physician for close monitoring.
So this is a carryover recommendation from the first.
Yes.
Because doses, with hypertension, doses are everything and titration, isn't it? Dr. Sivile?
Yeah. So I think that shouldn't be surprising. Someone who has chronic kidney disease, hypertension, is usually difficult to reach the target, is off targets. I think we should be looking at the drugs and the doses that would work well. So I think that's, so if then usually you just continue hitting with the drugs. Yeah. BD, we do add some beta blocker there, a loop diuretic do work a little bit better in CKD than in others. Yeah, so those are some of the options that you still have to, you can use. Yeah, but the point is, in someone who has chronic kidney disease like this, you most likely you need a lot of antihypertensive drugs and very high doses for you to control the BPs. Yeah.
Mm-hmm. And things like hydroalazine actually are excellent for such patients. But Professor Lloyd, please go ahead with your contribution. But there's a question here. They are saying they failed to switch the patient to Tafed despite us recommending that the patient should be on Tafed. Last I checked, TAFED was launched a good 3 months ago. Any comments, Dr. Prof? I can't see him, unfortunately.
Hi, Dr. Foloshi.
Yes,
Hi.
Prof.
I'm having technology.
We can hear you, Prof. We can hear you clearly.
Yeah, I'm sorry, I was doing other stuff then. I do not understand why they did not manage.
So Dr. Lusa, Professor Lloyd is saying, how have you failed to give this man TAFED when TAFED was launched June 5 months ago in Zambia? And is it supposed to be in all provincial pharmacies?
Yes, doctor.
So why have we had challenges getting TAFED when it's available? Why is this man on 5 tablets plus the antihypertensives and his psychosocial issues?
Available at national level or at provincial level as Eastern Province?
It's available at provincial level as far as I know.
Yeah, I think I must add that last time this issue came up as in Eastern Province, we spoke to the provincial pharmacists and we asked them to get this, so they should have it.
Okay.
And also, you know, bringing drugs to any part in the country, it can take maximum 2 days, especially if you're talking of for a patient or so. Now we're even within a day the patient receives.
Okay, thank you. Dr. Lusa, you may need to have to recheck it.
Yes.
In case it's been a while. So then we have a question on his psychosocial issues. The good news is that this gentleman is suppressed, but he's still struggling. Dr. Lusa would like to know how we can offer additional psychosocial support for these patients. Do we have any contributions from the lovely network on this? How do we assist this 79-year-old man? So we've talked about the control of his hypertension, using up titration of available drugs and adding better drugs like hydralazine and loop diuretics and beta blockers. We've talked about TAFED being available. If it's not available, as for the psychosocial issues, how do we help this gentleman?
Okay, yeah, so the question raised is very interesting, where he still blames the wife of contracting giving him the disease. So this is a familiar scenario you get in the clinic when you're seeing patients. Sometimes the blame game does come up. I think we have different approaches, but personally I'll give what I usually do when I meet clients who say that. I think the first point is for them to get to accept the disease, that they are sick, and they need treatment. They need to reach that point where they need to accept that. When it comes to who got the disease and who gave who, what I usually tell them that it's usually difficult, even scientifically, to actually prove that you got the disease from someone or somewhere, Yeah. So, and that in that scenario, it tends to be quite immaterial to really look at where you got the disease from, but really to look at the fact that you now have the infection and there is treatment for you. And let them project the future as opposed to looking at the past, to show them that if they are on treatment, the way this patient is, that if he's on treatment, he will be suppressed and he can live a near normal, life if he can adhere to the treatment. So, yeah, I know other people have different approaches. Yeah. Dr. Chanda.
Okay. Good afternoon. So, I think one of the areas I really worry about patients with chronic diseases is the fact that a good number of them would have some element of depression. And this man sounds like one such candidate. Francis, probably want to comment on this. I think when you have done all your psychosocial counseling and you still have that roadblock, you have to think about evaluating for depression and other mental health, and then refer appropriately. That could actually be a solution.
That's a good one. That's a good one.
So we still have a comment from Dr. Simenda.
Or even better.
Yes. All right. Good afternoon to the network.
Yes.
Yes, at 79 years old, we are looking at 3 risk factors for this man. First is the age, and we recognize that at 79 years, there are natural brain changes that occur, although they occur at different rates in different individuals, but we know that the brain mass will reduce. Number 2, risk factors, we have hypertension and the HIV. Both of these agents affect the brain, and we know for hypertension, even at good treatment, you have persistent insult to the neurons and you get loss. And for HIV, we also know that as good as 80% of the patients will have neuropsychiatric changes. So we have 3 risk factors, and certainly we expect some mental health problem. The only way to do is if we are able in East Africa, Eastern Province, you could still try and assess for changes. The first one would be for mild to moderate cognitive changes or persistent changes, or indeed screen for early dementia. He would benefit from a continuous cognitive therapy like this is talking through about this situation and recognizing his age, and of course optimizing all his treatment for hypertension, for the HIV, and recognizing that 80 years is that time. So this can really help in recognizing, in sorting out his current situation.
Excellent.
It's okay.
Okay. Very well done, very well said, Dr. Simenda. I was actually thinking of calling Dr. Angel Chira. I think I saw her here, but you've done a great job, and we are just winding up. Just to wind up to the recommendation, we believe TAFED will be available. That will help with the pill burden. Again, he's old, so this is a man that really we need to narrow that spectrum. And also, for the people have come up with the fact that we are off target with a lot of things like hypertension, the renal function is also off target. He's old, he's got HIV. We need to optimize treatment for all these disease processes in order to limit the neurocognitive damage that has already happened. And also you may need to engage a psychiatrist, and you benefit from cognitive behavior. Lusa.
Yes, very much welcome.
Very. And ending on that very academic note, thank you so much, we appreciate it. Davis, what is the topic for next week before we log off? So it's quality assurance in HIV testing with Dr. Nancy Ziongwe. Thank you all for joining us. Thank you so much to our new mentors. And we want to see you next week at 2:30 talking about HIV and quality assurance. And thank you to Dr. Sivile and maybe Mumba. You've been very good. And it's a wrap.